Hi, I'm Zena, Aldridge, and I'm a dementia nurse consultant with Norfolk and Waveney CCG. And this afternoon I'm going to talk to you about distressed behaviours. For many of you, this might be a new way of reframing the term. You might be more familiar with the word or the phrase challenging behaviours, which is something that is used quite frequently when just talking about behaviours that we perhaps see challenging as professionals when looking after people with dementia. I'm hoping by the end of this session you might think slightly differently, and I think you might be able to recognise that often the behaviours that we see as challenging are actually a means of communicating distress. So the aims of this session is to consider what we mean by distressed behaviours, because it's a really broad concept, it's a really broad term. It can mean different things to different people in different contexts, depending on your own experiences, how you manage those particular behaviours and how they make you feel. Start to explore and reframe behaviour as a form of communication, perhaps, as though for those people with dementia who may not be able to communicate their needs any longer, or may find the words very difficult to find, and so actually behaviour is a means of expression when they need to communicate an unmet need. And start to think about how, as professionals, we can support people who might be distressed to make them feel less frightened, less uncomfortable, less frustrated, and give them a better quality of life than they perhaps might be experiencing at that time. So what do we mean by distressed behaviours? I would say that I exhibit distressed behaviours all the time. My husband certainly would. If we start to have an argument and I perhaps get a little bit frustrated, I might slam a few cupboard doors. I'm not considered challenging, potentially, but in a different context, that might be seen as challenging behaviour because people are frightened, they don't necessarily know where that behaviour is going to lead. But we all behave differently in different scenarios based on, as I said, how we feel, our past experiences, and how vulnerable we might feel, and need to defend our space and make ourselves feel safe. So it might be that we behave aggressively, and that doesn't mean that we start punching each other. It might be that our body language changes, we're verbally aggressive, we might push someone out of the way. But again, that can feel really, really threatening in an environment where you're perhaps caring for someone who you don't know particularly well, and you don't know where that aggression is going to lead to. So it's appropriate to feel uncomfortable. It might be that people are just shouting, they're shouting out a lot, repeating the same words over again. But it also might be that they're very restless, pacing around, quite agitated, speaking rather rapidly. All those things, again, that we might find really difficult to cope with if we're not sure and we haven't had the training to manage those sorts of things. All these other things such as crying, groaning, again, not necessarily seen as challenging, but they could be seen as distressed behaviours. So they might be, again, a means of communication. People often, particularly in residential care, but also in their own homes, might be constantly going to the door and asking to leave, asking to go home, and that can be really difficult to deal with. But again, it's generally a sign that that person might feel that they're not safe in the environment they're in, they may not recognise it, it may not be familiar to them. So again, thinking about how that person might feel is really important. One of the other things that we need to think about is the fact that not all distress behaviour is overt. Sometimes it's really subtle, so it might be that actually the people that we see as more distressed are those that are exhibiting the shouting, the challenge, the offensive language, they might be being aggressive, but actually someone who becomes withdrawn and doesn't engage might be equally distressed, but finding a very different way of demonstrating that distress. And it's often, in my personal experience, I often get called to environments where someone is seen as challenging, I say that in the loosest possible terms, to give them extra support, where actually those people who are less, who are quiet, who are withdrawn, are equally challenged and needs that extra support. So we need to really think about that differently. It might be that people are resisting care, and in whatever environment you're in, that's really, really difficult, balancing what's best for the patient and in their best interest, or the resident, and actually what's needed to be done. Do we actually need to do some of these things? Do we need to think about whether this person is feeling really threatened and vulnerable? I always think about situations with showers and baths, for example. If you imagine you're a person of an older age who perhaps was brought up with a bath, not a shower, because they're fairly recent inventions in living memory for many people. Can you imagine being taken into a room, having your clothes taken off, sat on a seat, and actually someone hosing you down with water? That probably doesn't feel very therapeutic. That probably feels really scary and quite invasive if you don't understand what's going on. But thinking about someone going into a bath, for example, which is a familiar object, it's slightly less brutal, I would say, in one ways, in the fact that you're not just skirting a hose at someone, but you're actually getting into a nice tub of hot soapy water. That again may feel very different. So again, just putting yourself in their shoes really. What might this mean? How might this be interpreted? Not sleeping at night. I often get asked to work with people because they say, oh, the person with dementia is not sleeping at night, and that's really difficult to manage. It's difficult to manage probably in the environment, but it might be that that person's been sleeping all day and so is up all night. They might be hungry, for example, because they've slept too much during the day and they've missed meals. It might be that they're getting up at 3 o'clock in the morning because they used to be a dairy farmer, and actually that's their normal time to get up. So again, it's thinking, is that distress behaviour, or is that just them, living a pattern of life over a 24-hour period that's normal for them? So one of the things we always need to do is get to know the person. I think whatever session I deliver in this set of sessions is always my key message: please get to know the person and what's normal for them, because it will really help you understand some of these issues. Now, this might seem strange, but I've worked in dementia care across health and social care settings for nearly 30 years. I know that's hard to believe as I look only about 21, only joking. But ultimately, I do think a lot about how it might feel for someone with dementia, when they're perhaps in an environment they don't know, they might feel unsettled in, and how people might appear distressed and challenging, if you like, or aggressive, which is not correct. They're not challenging or aggressive, the environment's challenging them. But it takes me back to a time when, many years ago, I went out to Morocco on holiday. I used to go quite frequently, and believe it or not, I do speak a little bit of Arabic. Very, very basic, so please don't ever come and challenge me on it, because you'll catch me out. But I went on holiday, was in Marrakesh, and decided to go into the souk. There's a beautiful souk there called Jamal Fanar, and it's vibrant, there's lots going on. You've got snake charmers, you've got leather handbags, you've got lots of spices and smells. Your whole senses are being really, really stimulated. I was with a couple of friends, but I kind of got distracted and went off. So I was looking at all these various things, getting very, very excited about, how I was going to spend my hard-earned cash while I was there, only to turn around a little while later and realise that I'd lost the rest of the group that I was with. Now, I started to feel my heart pound. I started to feel really anxious. It was very hot. It's very difficult to pick out things that you can fix landmarks. It's hard to find the landmarks because it was all canopied over. So then I started to feel my heart start to race. I was getting hotter, I was getting sweatier. And actually I started to think, oh my goodness, how am I going to get out of here? I haven't got a clue where I am. My hands started to ring, I started to rub my hands together because my hands were getting sweaty. I'd then start rubbing them on my trousers. I'm getting redder and redder in the face, and of course the more anxious I'm getting, the more I'm sort of jiggling around on the spot, and you can imagine people are looking at me thinking, what on earth is she doing? I looked probably a bit unpredictable. No one really knew what I was going to do next. People were giving me a much wider berth. I could see them actually looking at me with their eyes, they'd put their eyes down and avoid me at all possible costs. Now, bear in mind, as I told you, I do speak a few words of Arabic. Because I was so anxious, because I was so uncomfortable, even talking about it makes me feel my heart race. I can take myself back to that moment. I couldn't find the words. The words were here, but I couldn't connect them with my mouth and my voice. And so I'm getting more and more agitated, getting more and more redder. Now, I don't know what happens for you guys, but I know when I get anxious, often what it does is it stimulates my bladder. So not only now am I feeling really frightened that I'm going to not find my friends ever again, I now feel like I'm going to be vastly incontinent in the middle of a market. The toilets in Morocco don't look anything like they do in the UK. The writing doesn't look anything like it does in the UK, so it's not like I can find anything. People are giving me wider and wider berth because I'm getting more and more anxious. And then this lady just comes along and she looks me in the eye, and all she does is just touch me on the hand. And then she just says there. Automatically, I could feel my anxiety levels drop significantly. She'd seen I was distressed. She'd seen that I was frightened. And just her touching my hand validated that fear, and I thought, someone's going to help me. Now, she suggested for me to stand still for a moment, and she went off and got this young chap who came along and started speaking English with me. And I still joke to this day thinking, well, how did he know I was English? I could have been German, Norwegian or anything. My theory is there's a lot of English women who do exactly the same thing in Marrakesh on a regular basis. But if you take yourself back from that scenario, do you think that's any different to how someone with dementia might feel at any point in any given time? They suddenly become disorientated, perhaps. They're confused as to where they are. They might not be able to find the toilet, and they might not be able to find the words to enable them to tell you what the problem is. I have to say it's probably the closest experience that I've had, and it really helps me when I look at someone who's distressed to think, what might be going on? Why is this person distressed, and how can I help them? And the value of non-verbal communication is so important, both from you and from that person. Thinking back to that scenario playing out, wouldn't it have been helpful to know what was going on for me at that point in time? You know, nobody knew me. They just saw this woman who looked really agitated in that environment. So it's really important to kind of think about, hang on a minute, what is the context of the behaviour that we're seeing? So think about ABC charts. They're a really good mechanism for trying to document some of the behaviours that you might see someone exhibiting. And I think what we need to reframe them as is a means of capturing when someone's content as well, because if someone's feeling very calm and content, it's really important to understand what's going on at that point so that we can also understand why someone might be distressed at another point. So an ABC chart stands for antecedent, so basically what was happening at the time, what was going on. Was there a lot of stimulation in the environment? Were there particular people around? Was the person, looking for the bathroom? Any clues that might be giving us an idea of what was happening when that person became distressed. B is for behaviour. Well, what is the behaviour? What is it that we're seeing that person do? And actually reminding ourselves that just because we might find it difficult to manage, it doesn't necessarily mean that it's distressing for the person. But if it is distressing, why is it distressing? What's triggering that behaviour? And the consequence, what did you do? What happened in the environment that changed that situation? So did you talk to the person? Did they move into a different room? Did someone leave the room? Were you able to take them to the bathroom? Were they hungry? All those kind of things. Get those documented so you can start to build up a pattern of behaviour, and then it might help us understand how we can support that person more effectively. But I think all too often ABC charts are seen as a means of demonstrating what's referred to as challenging behaviour, and that's only part of the story. We really do need to understand what's going on when a person's calm as well. So please, do think about that. Then often seen as quite challenging and time-consuming to fill in. But doing these for 2 or 3 days, if you start to notice a pattern of behaviour changing, can really give you the cues and clues you need to resolve that matter for that individual and actually make them feel more confident and comfortable in their environment. So what might be some of the things that you need to consider? Does the person have difficult communicating? And that's not just verbally, it might be about the fact that they need glasses or hearing aids. I interestingly went into a care home some time ago, and there was a lady in there who had been exhibiting behaviours that the staff found difficult to manage. She was shouting a lot, she was waving her Zimmer frame at them in the afternoons. They'd asked for a nurse practitioner to come out and assess her. That nurse had done a screen to see whether they thought she might have dementia, because this lady didn't have a diagnosis of dementia. She felt that this lady might have dementia, so asked the GP to go out, and I happened to be with the GP on this occasion. And when I went to see the lady, there was something that didn't feel like she would be someone who was exhibiting cognitive deficits or cognitive difficulties in other ways. But I did notice that she had 2 hearing aids in, so I gestured to her, "Are your hearing aids turned on?" At which point she went and popped them out so I could have a look. Well, they were both switched on, but I thought, you know, I'll change the batteries. Let's see if the batteries need changing. So I went out and asked the care staff whether she could actually have the batteries changed, which they did. Popped the hearing aids back in, and talking as I am to you guys now, she told me to stop shouting. So this poor lady had been seen as someone who might be developing a cognitive impairment. She'd been seen as challenging with the staff. There was a view that she might actually be moved from a residential unit into a specialist dementia unit because they were finding it difficult. But imagine how challenging and frightened that lady was in the fact that she couldn't make herself heard or understood and couldn't understand what others were saying to her. So if you imagine that she had had dementia and was experiencing those things, how difficult was that situation be again? You know, even worse when you perhaps can't make sense of your environment in the same way. Could they be frustrated? We've talked about perhaps finding the toilet, and certainly in my own example, you know, I was certainly feeling distressed because I couldn't find the toilet. You know, there's nothing worse than thinking you're going to be incontinent in front of people that you don't know. I mean, that's not dignified and it's really unpleasant. But actually, what else might be going on that they're frightened of? You know, I've talked about perhaps thinking about baths instead of showers. Some of the things in the environment might be feeling really invasive and scary. So thinking about that as well. Could it be that actually there's someone that they don't get on with particularly, and that might be nothing to do with dementia or being, you know, distressed in terms of behaviours, but actually just them exhibiting the fact that they don't want to be around certain people. It might be a family member, it might be a resident in a care home, it might be a member of staff. But it might not be a personal thing, it might just be we recognise that and we ensure that those people don't have to spend too much time together if it's going to make it difficult for all of those concerned. So really think about what might be going on, and your ABC charts can help inform that. So thinking about changes in behaviour, we need to think about whether it is a symptom of delirium. And we've got another session talking about the differences between dementia, depression and delirium, which I'd urge you to watch. But actually, people with dementia are highly likely to develop a delirium if they have difficulties around particular aspects of their health and well-being. If you use the words pinch me, you can use the first letters to remind you of some of the things that you might want to consider if someone's behaviour changes. So again, not just assuming that those changes in behaviour are as a result of dementia, but are there other things that are going on for that person that might make a difference? So if, for example, is the person in pain? You know, are they pacing around because actually they've got terrible dental pain, for example, that they can't communicate? Because that could be really difficult and challenging, and often not that obvious to be able to see it when you're assessing someone's pain and where it might be coming from. Infection is the next one. Now, we often have a propensity to consider whether someone with dementia is living with a urinary tract infection. So first thing that often happens is a urine sample is taken, it's dipped, and if it's negative, it's kind of ruled out. And again, there might be this, what we call diagnostic overshadowing, which means that people say, well, it is just a progression of their dementia. Well, actually, it might be an infection caused by another reason, for example, a chest infection, it might be a cellulitis, an infection of the leg, for example. All of those things could be attributing to those changes in behaviour. Thinking about nutrition. Now, people with dementia may miss meals because, you know, they're falling asleep at different times, or they may not be hungry at the times that suit us. their 24-hour period may look very different. So it might be that in the middle of the night they might need to have something to eat and drink. So I've often given people a sandwich and a cup of tea in the middle of the night, and that has resolved their distress. They've gone back to bed because actually their need has been met. Constipation can be a really big issue as well. Often people are on pain medication that can make them constipated, or perhaps they're just not eating and drinking sufficiently or regularly in the way that they would have done before. And constipation can be incredibly uncomfortable and cause incredible toxicity. It's not unheard of for people to be admitted to hospital and be taken in seriously and have to have surgery as a result of constipation. But again, understanding their bowel movements is really important. Hydration. So if we think, going back to, people with dementia are likely to get delirium. So we know that we can reduce those risks if we make sure they're adequately hydrated, and that reduces their risks of urinary tract infections, for example. So, making sure that they're prompted to have those fluids, and actually they just might be thirsty as well, but not be able to express it. Medication. People with dementia have multiple conditions often, and that generally means that they have lots of medication that they have to take. Well, over years, those medications may not have been reviewed. The person's body may not be able to tolerate those medications so well. So it's often really worthwhile either a pharmacist or a GP reviewing that medication to see if there are medications that can then be reduced or stopped as a result of perhaps some of the symptoms that person's exhibiting. And thinking about the environment as well. If I go into Primark on a Saturday afternoon in Norwich, I find it incredibly hot, incredibly busy, incredibly stressful, and I can certainly feel my behaviour change. I'm not relaxed, I'm not, enjoying the environment, and I'm certainly, wanting to get out of that space pretty quickly. So it may well be that that's something that you might want to consider. Is it too hot? Is it too cold? Is it too noisy? It might be great that everyone else is enjoying a session perhaps in a shared area, but that person might want some solitude and be removed to their own space so they can just, feel more content in the environment they're in, or vice versa. So do think about these things, because it's really important to reduce some of the risks of delirium, but also see them as perhaps triggers of unmet needs that the person might be able to be trying to communicate with you. So here's some tips for managing distress in those people, not just with dementia, but any of your residents or people you care for who might be showing signs of distress. So first of all, try and identify the cause of the stress, and that might just be through looking at the ABC charts if they're not able to communicate. But actually, don't forget to ask. It might be easier just to say to the person, is there something upsetting you? What is going on for you at the moment? Can they actually articulate it? In which case, the problem might be easily resolved. So don't ever forget to ask them. Try and remain calm. I know that's really difficult, particularly if someone's shouting at you or they appear aggressive. It can be really difficult when you're frightened yourself to remain calm. But just trying to keep a relaxed posture and try not to look aggressive yourself is really, really important. So just have that little bit of self-awareness about how you might be perceived if someone was looking at you at this point in time. Use a steady and calm tone of voice. The more elevated your voice gets, the more difficult it is to de-escalate the behaviour that someone else is exhibiting. So try, as I say, even if it's really, really difficult, try and keep calm. And if you need to step out of the situation, don't be afraid to step out of that situation for a little while to gather yourself, because the last thing we want to do is make you feel uncomfortable or put you in a position where you feel unsafe. Try and maintain eye contact. Again, going back to that scenario of the lady who just gave me some eye contact, it meant that I was connecting with her. Although I wasn't able, we weren't conversing, we connected. And I think that's really important, because it's like you're acknowledging that that person's distressed and you're trying to do something about it. Again, we talked about the environment. Try and keep it calm. Try and stop too many distractions going on in the background, because again, it'll be really difficult for that person to focus on you, and vice versa, to try and find a resolution to what's going on. So all of it is just keep it calm as best you can. Your non-verbals again. It doesn't mean you go and give someone a great big bear hug, but just a tap on the hand, it's enough. And again, don't do that really quickly because it might be seen as something that's going to be aggressive. Just gently reach out to that person and let them know you're there if it's appropriate. Of course, don't ever put yourself in danger if you think that person's going to come back and be competitive with you. We would never want you to do that. Do what you feel safe and comfortable with. And if they are distressed by a change of routine or, trying to do some personal care interventions, which often tends to be something that can cause some flashpoints, walk away, come back at a later time and see if that person is more comfortable at that point and you might be more comfortable at that point. Or ask another colleague to perhaps go and try, because it doesn't necessarily mean that you're the problem, it just might mean that it just needs a different pair of eyes at that point in time. But always ask for support each other, and try and get that support from external colleagues if you're not able to find out what the situation is yourself. That's what we're here for. I think for me, the key message from this session is very much about put yourself in that person's shoes. Don't look at the dementia as the first cause of any changes. Think about what is going on for that individual, what might have changed, what might you need to change to support them. But remember how important just a smile, eye contact and body language is for someone who might be incredibly frightened. Certainly in the example I shared with you, the lady who supported me didn't say one word, but the moment she made eye contact with me and touched me on the hand, I knew that she had seen I was distressed. Remember, this could be any one of us at any time. What would you want someone to do for you? And I think if you think in those terms, it will really help you to solve the problems that you might be facing with looking after people with dementia on a day-to-day basis in a way that you didn't realise that you had the skills to do. So good luck with that one, and I'm sure you'll be really successful if you think slightly differently.
Our first question from providers is, why would some people with dementia demonstrate behaviours that are very different to how they would behave before having dementia?
I think, again, a lot of that comes back to what we've discussed in the session, really, thinking about the inability to communicate perhaps in the way that they get used to say when they feel distressed, not being able to perhaps feel comfortable in their environment or recognise things. So it's not necessarily that their behaviour has changed, it's their ability to manage it and communicate their needs has changed. And I think there's often this propensity for people to think, well, that person was really calm before, why are they aggressive? Is it the dementia doing that? Well, yes, to a degree, but it's more about how dementia affects them that creates that scenario. So it's thinking about what was important to that person before. Is that person not being able to be heard? Are they bored? Do they need some future engagement? I mean, we often talk about, finding people a means of doing something that they seem as valuable, but that's not listen to Dame Vera Lynn and playing bingo for everybody. That might be about they might just want to go for a walk, they might just need to feel valued. And all those things are really important. So it's kind of like trying to solve a jigsaw in a way. It's thinking through all the things that might be impacting on them and thinking about how we can be creative in supporting them. So there's no hard and fast rules about why dementia affects people in different ways. There's so many different dementias, they affect the brain in different ways. So it's, again, going back to knowing the person, getting to know that individual.
Our second question is, how can staff members be best supported through managing more distressful behaviour?
I think it's about, again, supporting them to have the skills and experience they need to feel more confident and competent in meeting the needs of those people who might be distressed. There are no two people who are going to behave and respond in the same way as, in the general public. None of us respond in the same way. It's based very much on our experience. But I think it's about giving people the opportunity to talk through their concerns, putting the infrastructure in where they feel supported rather than blamed if they're struggling with it. And as a nurse, we are very fortunate to have things called called clinical supervision, where we talk these things through. And I think it's really important that social care staff are given those same opportunities, because they can share their experiences with others, learn together, but also work through and reflect on why things might have happened and think about what they might do differently next time.
And our final question: how can someone best support a person dealing with sleep disturbances?
Again, it's about what is a sleep disturbance caused by. So it might be that actually that person's routine has changed and the sleep disturbance is difficult to manage within the environment that they're in. So of course, if they're at home with a family carer, that family carer is likely to be up all day, managing the tasks of the house, supporting that individual, and really need their sleep. But the person with dementia might have slept a lot during the day and actually not want to sleep at night. So it's difficult, and that can be replicated within care home settings as well. It's probably easier to manage in a care home setting because you have staff there 24 hours a day, but obviously in a home situation, it's difficult if there's no extra support. So it's about trying to set some routines. Again, if someone's busy during the day and occupied, they might be more likely to sleep at night. Thinking about, are they hungry? Is it worth giving them a snack, something to eat before they go to bed? If they've missed meals. But we need to move away from thinking about medication as the only solution. It could be that actually if that person doesn't want to sleep, maybe put some music on so they'll rest. So think about why is it challenging? Is it the fact that the person's not sleeping at all, in which case we need to look at that because that's not good for them if they're going for long periods of time without sleep? Or is it actually that their routine just doesn't fit with ours, and how can we change that in some way and modify it to make sure that it's not affecting either the family carer or other residents and staff in a negative way?
Thank you for watching. If you would like more information, please visit Norfolk and Suffolk caresupport.co.uk, where you'll find further training on our learning portal. The link for this website is in the description down below.